So it's a distinct pleasure to be here. I started my fellowship here with Mike Rosenthal in 1977. I was 31 years old, and when I left Stanford, I was 39. So I spent the decade of my 30s here, and it was one of the happiest decades of my life. Our daughter Sarah was born here at Stanford Hospital, and we still have wonderful ties. And it's always been a great privilege and pleasure to come back. And when I come back to the Bay Area, one forgets how beautiful it is, especially up in the hills, and the quality of life is really something. On Thursday morning, I had the distinct pleasure of listening to Dr. Bateman give his endowed lecture on obstetric anesthesia and the research that he and his colleagues had done in looking at the impact of medications on maternal health, and then drove up to Hartford Airport, got in the plane, and looking out the window, crossing the Sierras, and then into the foothills, and everything was green. What a time to come to California. So here we are back in the surgical ICU. Ron will remember this very well back in the day, and the hairstyles have changed a little bit since then. At the end of each month, I would invite the residents that had rotated through the ICU to come up to Ridge. At that time, Ridge Winery was just getting going, and they were quite happy for you to bring your picnic stuff, sit at one of their tables, buy a bottle of their wine, and enjoy a lunch with families. Palo Alto in the late 70s, and I always enjoyed the murals on Hamilton and Varsity. So what I'm going to be talking about is the topic of advanced aging and the critically ill. Does it really matter? And it's going to be somewhat wide-ranging, as you'll see. I don't have any disclosures. When I was going through some of my stuff, I discovered this, and I'd always potentially had an alternative career as a cartoonist, but this is something that I did at the age of 16. Standard 9, you can see down the bottom corner, is equivalent to 11th grade. And we've been talking about Shakespeare and As You Like It, and this was written in 1599. And I just want to take you through this because when you think that this was written, more than 400 years ago, how appropriate it is to this day. All the world's a stage, and all the men and women merely players. They have their exits and their entrances. And one man in his time plays many parts, his act being 7 stages and ages. At first, the infant mewling and puking in the nurse's arms, and then the whining schoolboy with his satchel and shining morning face, creeping like snail unwillingly to school. And then the lover, sighing like furnace with a woeful ballad made to his mistress's eyebrow. And then a soldier full of strange oaths and bearded like the par, jealous and honor, sudden and quick in quarrel, seeking the bubble reputation even in the cannon's mouth. And then the justice in fair round belly, with good capon lined, with eyes severe and beard of formal cut, full of wise saws and modern instances. And so he plays his part. The 6th age shifts into the lean and slippered pantaloon, with spectacles on nose and pouch on side, his youthful hose well saved a world too wide for his shrunk shank, and his big manly voice turns again towards a childish treble, pipes and whistles in his sound. Last scene of all that ends a strange eventful history, his second childishness and mere oblivion, science teeth, science eyes, science taste, science everything. I guess I'm somewhere between Pantaloon and oblivion, but it's very interesting as one gets into this stage of one's life that you see the trajectory of life in a totally different perspective. And one starts looking back rather than forward. And I think I'm going to try to share some of that with you this morning. This is another perspective. I love the New Yorker covers, and translating this into academia would be kind of like this. I'm not sure where Professor Emeritus fits into this, probably still lying on the beach somewhere. And then I love, Betty Davis's comment, because that is, I think, very appropriate. I'd like to start off just talking a little bit about epidemiology and biology of aging to kind of set the scene. And I think we're all familiar with the dramatic increase in life expectancy that's occurred in the last 150 years. And in truth, the vast majority of increase in life expectancy in the last 100 years has been through the eradication of childhood illnesses through vaccination. And now we're trying to increase life expectancy on the older population. And to put that in perspective, here's a chart that shows the growth in the world population. So total population since 1950 in the world has grown from 2.5 to 8 billion. But if you look at the red line, you'll see that the proportion of those that are under the age of 70 has increased threefold. The proportion of those greater than 70 has increased sixfold. And if you look at the US population from 2000 to 2020, it's increased from 281 to 331 million, but the proportion of inhabitants greater than the age of 65 has increased from 34 to 56 million and from 12 to 17%. So in our practice, clearly, we're going to be encountering a greater proportion of older patients, and that's what makes what I'm talking about all the more pertinent. I think this is an interesting perspective from Dr. Oshansky, who says, modern medicine advances in the medical sciences are tightly focused on a quest to find ways to extend life without considering either the consequences of success or the best way to pursue it. And he goes further to say that from the perspective of physicians treating the patients, it makes sense to help them overcome immediate health challenges, which we do every day. But further life extension in increasingly more aged bodies will expose the saved population to an elevated risk of even more disabling health conditions associated with aging. And he makes the point that if we find a cure for cancer, then the prevalence of dementia is going to become greater and greater in the surviving population. This has an interesting impact on healthcare, and Dr. Watts points out that in recent years in the United States, 75 to 80% of healthcare dollars are spent on high-tech interventions. We're all too familiar with those, dealing with the established diseases of aging, diabetes, hypertension, heart failure, and with a mixed impact on patient quality of life. Working in the operating room in the ICU, we deal with acute situations, but we seldom have the opportunity to see what happens to our patients once they leave the hospital. The CDC estimated that in 2010, $55 billion in healthcare were spent in the last 2 months of life. Less than 5% of healthcare dollars are directed towards the prevention of the diseases of aging, with little or no focus on the slowing of the aging process. In other words, increasing lifespan without increasing health span. So what is health span? And what is the health span lifespan gap? There's increasing interest in this concept. Lifespan is the observed individual duration of life. It's if you take someone, how long did they live? That's the lifespan. Health span is the duration of functional independence and productivity. And the health span lifespan gap is shown here, that today we are extending our patients' lives, but the last decade may be spent in dealing with age-related disease, even if the patients are living, and they're becoming more and more functionally dependent. And so our goal should not necessarily be to extend the duration of life, but to extend the duration of functional independence and close that health span, lifespan gap. And this has led to the development of geroscience, which is really specifically looking for ways to do that. This is an interesting perspective looking at the 183 members of WHO. It's now down to 182. And the United States actually has the largest health span, lifespan gap of all 183 countries. And this morbidity burden seems to be predominantly through dementia, substance abuse, and musculoskeletal disease. So geroscience, this is sort of an example of what our cardiology colleagues have done in terms of strategies to decelerate biological aging of the vasculature. And on the left, the behavioral changes that one would hope ultimately would be instituted from childhood onwards, and not when the patients are 60s and their 70s and it's an irreversible situation. And there's an increasing list of drugs that are being looked at that potentially could slow down cellular aging processes. So biological aging, only about 20 to 30% of biological aging is genetically determined. There are many other factors. Women live longer than men. Nobody truly understands why that's happened. It's changed historically over time. Obviously, chronic disease burden, the environment, especially subject to pollution, lifestyle, diet, exercise, sleep, social connectedness, socioeconomic status, and stress. And this points out that, you know, aging starts from birth, but it varies as we get into our midlife in terms of the changes in organs, mature adulthood, the altered hormone levels, and the mechanical and structural tissue changes. And then we get into what could be called late adulthood with age-related diseases, frailty, and multimorbidity. And these lines are looking at individual curves. And the point that is being made here is no two people age at the same rate, that we have to individualize biological age and or chronological age and physiologic age. The longest known in terms of the duration of life in the Western world is Jeanne Calment, who lived from 1875 to 1997, 122 years. This is a picture of her as a young woman. And she is quite interesting in that to her last day, she would smoke 2 Gaulois a day and have some chocolate. And she had a lawyer who worked out an arrangement with her that he would pay for her apartment when she was 95, with the understanding that when she died, he would get the apartment. Unfortunately, she outlived him at least 20 years. So here's another example of health span. Elaine Lalande was born in 1926. She was married to Jack Lalande, and founded the first health club and gym in Oakland in 1936, years ahead of his time. She is 98 years old. From what I could see on the web, in August of 24, she was still alive. Works out 20 minutes every day. She's got a little mini gym, and she says, I don't want to be old when I'm old. If we look at life expectancy by census, you'll note that the red would be the shortest life expectancy, and the yellow would be the longest by county. And you can see that there are marked disparities across the United States, especially when you compare the Southeast with the Northeast or the West Coast. And this goes down to neighborhood by neighborhood. So here's a pictograph from the Washington Post of DC and surrounding Maryland. And the blue dots are households or locations with long life expectancy, and the red dots with short life expectancy. And when it's analyzed, Montgomery County, 79% white, 8% Asian, 1% black, 90% have college degrees, less than 3% below the poverty line. Life expectancy at birth, 95 years. Right next door in Barry Farms, DC, 92% black, 3% Hispanic, 7.6% with a college degree, 70% below the poverty line, life expectancy at birth, 63 years. So I think the message there is that socioeconomic circumstances and everything that goes along with it in terms of stress, pollution, and so on, have a dramatic impact on life expectancy. Next, I'd like to segue into just a kind of a brief overview of the physiology of aging and how it affects every single organ system. And this will be of necessity brief. Just to start off, defining very important concepts: robustness and resilience. Robustness is the ability to resist a physical challenge or stress and maintain homeostasis. Resilience is the ability to recover from a physical challenge and stress and return to homeostasis. So in a sense, preoperatively, we're assessing the patient's robustness. How they do, depending that everything goes well, depends a lot on their physiologic resilience. We all undergo neurologic decline with a gradual loss of neurons through oxidative stress, inflammaging, apoptosis, microvascular and macrovascular disease, and then an increasing incidence and prevalence of degenerative neurologic disease, the presenile and senile dementias, Parkinson's, Alzheimer's, and motor neuron disease. Cardiovascular aging, I think it's really important because it's not talked about enough that as we age, our blood pressures tend to trend upwards and we develop left ventricular hypertrophy and impaired diastolic relaxation. So older patients do not tolerate hypertension and tachycardia. They need the time for ventricular filling. And it's not something that one picks up clinically. The only way to really detect it is through echo. Increasing incidence of aortic sclerosis, impaired chronotropy and response to exercise and to position change, impaired conduction, which means that there's increased risk of arrhythmias that arise. So the cardiovascular status of patients will progressively change in this direction with age. Jonathan Mike, my friend and colleague Jonathan, did his residency here at Stanford. And my very first night on call as a fellow, Jonathan was a fourth-year medical student. And I was fairly nervous because, first of all, I'd never worked or lived in the United States before coming to Stanford. And secondly, I suddenly was thrown into covering the ICU. And Jonathan patted me on the back and said, "Don't worry, Rob, I'll take care of you." And he did. And he then went on to the Brigham and actually took my place as chief of anesthesia at the VA in Durham. So we've had a long relationship, and he produced this wonderful textbook. Unfortunately, never had subsequent editions. Here showing the comparison of the arterial tracing between a young healthy individual and an elderly hypertensive individual. And the important point is that vascular distensibility becomes less and less, and that contributes to the left ventricular hypertrophy and the widened pulse pressure. And so as we age, we transcend from a high incidence of systolic diastolic hypertension, which would be defined as greater than 140/90, or more recently, greater than 130/90, and what is called isolated systolic hypertension, or wide pulse pressure hypertension, defined as a pulse pressure greater than 50 with a high systolic and a relatively low diastolic. And you can see the differences in hemodynamics between the two types and the difference in preponderance of age. And Solon Aronson and his colleagues at Duke did a prospective study on a large number of patients undergoing coronary artery bypass grafting, of whom 30% had isolated systolic hypertension with an increased risk of adverse outcomes by 30 to 40%. So we need to pay attention to this. We're so focused on diastolic hypertension, but in terms of coronary perfusion, it may actually be protective. And patients that have wide pulse pressure who come to surgery and anesthesia are going to have much greater fluctuations of blood pressure during anesthetic induction. They'll drop their pressure. If the anesthesia is too light, they're going to get extremely hypertensive, and they are at risk of myocardial ischemia anytime their diastolic pressures fall. This is a study done by Margaret Wood, who is our chair at Columbia for many years, on awake patients receiving an infusion of sodium nitroprusside. And what is shown here is that for a given dose of sodium nitroprusside, there seems to be a much greater impact on a fall in blood pressure with increasing age. And what they showed was that this is directly related to reflex increases in heart rate, that elderly patients do not have the same baroreceptor responses and reflex increases in heart rate as younger patients. And this is something we need to take into consideration. In terms of our pulmonary function, there is increasing chest wall stiffness. There is progressive weakness of the pharyngeal muscles, impaired secretion clearance, and increased risk of aspiration, increased incidence of obstructive sleep apnea, whether it's related to obesity or to pharyngeal strength, impaired responses to hypoxemia and hypercarbia, really important in the recovery phase in the PACU, and increasing dead space, almost an emphysematous change that occurs with aging. In terms of the GI tract, impaired mastication, taste, and thirst, delayed gastric emptying, increasing incidence of GERD and reflux, increasing aspiration risk, increasing mucosal susceptibility to damage by non-steroidals, malabsorption, especially for nutrients, for the hematinic vitamins and vitamin D, calcium. So increasing incidence of B12 folate deficiency anemias and abnormal calcium distribution because of hypercalcemia. In terms of the aging liver, the increasing incidence of the metabolic syndrome with age and the distribution of fat around the viscera leads to insulin resistance and progressive type 2 diabetes and a pro-inflammatory state. And this leads to an increasing incidence of non-alcoholic fatty disease with age. There's impaired hepatic reserve and regeneration, so increasing vulnerability to acute injury, decreased resilience, and increased susceptibility to a fibrotic response, especially in terms of alcoholic liver disease or chronic hepatitis C. In terms of the kidney, we lose nephrons as we age, but the serum creatinine is actually a very late marker of this, because if we look at what happens with the serum creatinine as our GFR declines from a youthful 150 mils per minute, there's no change in serum creatinine until, in fact, our GFR starts to drop below 50 mils per minute. So this renal reserve is only detected when our GFR has halved. And from that point on, a doubling of the serum creatinine implies a halving of the GFR. So by the time you start seeing the serum creatinine go up, the patient has lost a huge amount of reserve. And especially in elderly patients with somatopenia, their creatinine production is going to be very low. And you can have a patient who weighs 40 kilograms with a creatinine of 0.3 and the GFR maybe, something done in the 40 mils per minute. And it might double from 0.3 to 0.6. And we still say, well, it's normal, but she's halved her GFR. And in fact, if we think about it, and we look at a youthful GFR of 125 mils per minute, and then by the time we're 60, it'll be down to about 80. And by the time we're 80, we're down to about 60. The GFR progressively declines, but that line is the line below which the serum creatinine starts to rise. So 20-year-old, 60-year-old, 80-year-old will all have a normal serum creatinine, but markedly different renal reserve. And so it's very useful in terms of evaluating aging patients to look at the estimated GFR, which really is only useful in a steady state. It's not going to help us with acute states, but it incorporates age and gender with the serum creatinine. And you can easily look up the chronic kidney disease epidemiology algorithm, and you can get an idea if it's greater than 60, the patient's within the normal range, and then there's stages of chronic kidney disease depending on whether it goes from 60 to 30 to 15 or less than 15, and there is a direct relationship between the eGFR and outcome after surgery. In terms of pharmacology, as a general principle, the vast majority of drugs that we use are lipophilic in order to be taken up into cells, but the body has to convert them to hydrophilic metabolites to allow them to be excreted in the bile and the urine. And there are two main ways of doing that: a very simple glucuronide conjugation, which is relatively slow, so that drugs that are glucuronide conjugated will be longer lasting, morphine, for example. On the other hand, more rapidly, drugs undergo active biotransformation by CP450 enzymes and have a faster half-life. Another example would be lorazepam, which undergoes glucuronide conjugation, relatively long duration, whereas midazolam undergoes hepatic biotransformation, shorter acting, but much more sensitive to advancing age and liver function and liver disease. And then, of course, there are the group that are directly metabolized in the blood that are independent of liver and kidney function. So there are some important considerations. First of all, the impaired pharmacokinetics that I've just mentioned in terms of hepatic biotransformation, and also renal elimination of active metabolites, morphine particularly, morphine 3-glucuronide and 6-glucuronide are active. Enhanced pharmacodynamic effects regardless of drug levels for all sedative hypnotic agents and drugs such as warfarin. Increased inter-individual variability, increased polypharmacy, patients on 12, 15, 16 medications, all with potential interactions. And much of the drug data that we see in the package insert has been obtained in younger subjects. Finally, the concept of immunosenescence, which is that our innate immunology is preserved, but acquired immunity is diminished in terms of our response to vaccination, for example. And there is chronic low-grade inflammation. There's involution of the thymus, diminished naive T and B cells with an impaired response to vaccination, impaired T cell memory, the recrudescence of herpes virus and herpes zoster, and then the low-level release of a lot of cytokines, creating really a low level of pro-inflammatory state, increased risk of infection, cancer, autoimmune, and inflammatory responses. And Aditi Gurkar, working in the Aging Institute at the University of Pittsburgh, has kind of led the charge on research into what are called senescent or zombie cells. And showing here are senescent or hibernating fat cells in an elderly person. These cells are present throughout life, and they get activated, especially in times of stress or for wound healing. But with aging, they start becoming redundant, and they are cells that have really undergone cell cycle arrest. They're not easily eliminated. That's why they're called zombie cells. They put out a lot of toxic fatty acids and that have been called senescence-associated secretory phenotype, and they're pro-inflammatory. They contribute to sarcopenia, metabolic syndrome, and organ system aging. So this is an area really of interesting research at this point. So with that background, what I'd like to conclude with is a kind of an overview of some of the considerations of the advanced age patient and intensive care. And I think you've gathered by now that almost everything that I've talked about is equally applicable to taking an older patient to the operating room as in taking care of them post-operatively. So elderly ICU admissions in the United States, greater than 1.5 million Medicare beneficiaries admitted to the ICU back 10 years ago. Comparing 1996 to 2010, you can see the trends in the extreme age, and the consequences: acute organ dysfunction doubled, discharge destination declined from going home to an acute care facility instead, and to hospice care. And so we can see this transition that has occurred over the previous decades. And why is this? Well, we know that elderly patients often have atypical presentations of disease processes, acute diseases, and there may be suboptimal management because, again, most guidelines are based on in adults 20 to 60, and there are a paucity of studies focused on the elderly patients. Decreased physiologic reserve, which I'd alluded to, the heterogeneity of responses to drugs, iatrogenic complications increase, sepsis and delirium, and this leads to prolonged ICU and hospital length of stay. The longer you're in the ICU, the greater risk you are for all the complications that can occur. And then there may be inappropriate timing and destination of discharge, and an increasing awareness of the importance of the post-intensive care syndrome, which affects patients and families. Whereas Ely and his group at Vanderbilt have done an extraordinary amount of work in identifying this, and they actually have post-ICU clinics with a psychologist and occupational therapists helping patients who can be totally devastated. And again, if we're working in the operating room in the ICU, we don't see what happens to the patients for weeks and months afterwards. And then, of course, post-discharge cognitive dysfunction. So what factors affect ICU outcome? If we're kind of looking at the older patient, are there things that we can detect? Well, obviously increasing age, we already alluded to, but again, everyone is different. And so we have to individualize for each patient. Pre-existing conditions, clearly is something we focus on a great deal. the indication for admission, and that's important, and I'll allude to that in just a moment. The concept of frailty is probably one of the most important and one of the most helpful that we can use. And ultimately, it's describing the patient's functional independence to functional dependence. And the consequences are really very important. And clearly, cognitive dysfunction is going to have a great impact on the ICU outcome. So look at the different indications: elective planned surgery, ICU mortality in the older patient, about 12% overall, hospital mortality, about 25%. That's still pretty formidable. Emergency unplanned surgery, very frequently falls and hip fractures and so on, a 1-year mortality, nearly 2/3 of patients. Their falls are a sign of increasing frailty. They're not going to heal. They're going to be bedbound, chairbound, and so on. Medical conditions, about half the admissions in the ICU, 1-year mortality, 80%. Circulatory shock, greater than 85 years, 1-year mortality, 97%. This is a study that was done in Belgium about 10 years ago, looking at 3 age groups, as you see here, and comparing their outcome. And I'll just draw your attention that less than 75 years with circulatory shock requiring vasopressors, mortality was 76%, 34% survival. That's pretty formidable. But when you look at the patients that are greater than 85, 3% were still alive at the end of 1 year. And it's hard for us to take that in consideration when we have a patient coming from the emergency room in circulatory shock. Sean Bagshaw in Canada, Calgary and his group have done a great deal of work on frailty, which is defined as a progressive loss of physical reserve. Could be due to chronic diseases, but it's often manifested by talking to the patient or family of unintentional weight loss, more than 4 kilograms in a recent period of time, progressive loss of physical activity, progressive exhaustion, kind of like post-COVID symptoms almost. Increasing malnutrition, I've alluded to the malabsorption that occurs, progressive decrease in BMI, sarcopenia, and then associated with that, a progressive loss of cognitive reserve with increasing incidence of dementia, and mild dementia may go undiscovered until a relatively late stage. And the bottom line is increasing functional dependence, and a very simple clinical frailty scale going from 1 to 8, as you can see here. And there is really a cutoff once you get up into patients who start to need help with more robust activities of daily living, dressing, cleaning, housekeeping, and so on. And these are just simple questions that can be asked ahead of time that can be enormously helpful. And Dr. Bagshaw went on to look at a group of patients, a mean age of 67, and divided them into those who had a frailty score of 4 or less, in other words, relatively independent functionally, and those with a score of 5 to 8, increasing functional dependence. And there was no difference in what we did for them in the ICU in terms of ventilation, reintubation, tracheostomy, vasoactive drugs, renal replacement, blood transfusion, surgery, reoperation. There was a huge difference in outcome in terms of ICU and hospital length of stay, hospital readmission, loss of independent activity, and 1-year survival. And just graphically, what you're seeing here is the probability of survival on the vertical axis and the follow-up from ICU admission on the horizontal axis. And if you look at the two extremes, the red line are patients with a clinical frailty score between 1 and 3, and the blue line are patients between 6 and 8, and 4 and 5 are somewhere intermediate. So simply assessing patient frailty by asking simple questions of the patient and their family can make an enormous difference to our interpretation of what this patient is going to tolerate in terms of decision-making with regard to elective surgery, and what we should anticipate in terms of what their recovery is going to be in terms of talking to the patient and the family and setting appropriate expectations. In terms of perioperative cognitive disorders, there's been some kind of order in terms of nomenclature, in the sense that emergence delirium is defined as delirium occurring within hours to minutes to hours after surgery. Postoperative delirium, days after until hospital discharge. Delayed neurocognitive recovery is defined as disorders that occur up to 30 days postoperatively, and postoperative neurocognitive dysfunction is a cognitive disorder that is protracted beyond a month. Deb Cully, who's now chair of anesthesia at Penn, when she was in Boston, did some groundbreaking work in terms of preoperative rapid assessment of cognitive reserve. And she found that, in fact, in the population she was looking at, about 5 to 10% of the population greater than 65 years had subtle signs of dementia. Mild cognitive impairment, about 35 to 50%, frequently undetected. Age is not a direct predictor because of the heterogeneity we've been talking about, but it's a great predictor of the risk of postoperative delirium. And it also predicts postoperative dysfunction. And a number of screening tests, the most popular one is the mini-cog, which is simply asking the patient to say, draw 10 past 11 on this blank piece of paper. And here you can see a patient doing it quite successfully. Here's another one who's got the numbers okay, but not the actual time. And here's a patient who simply can't even get the numbers right, and mild, moderate to severe cognitive dysfunction with a 3-item recall score. And in her study of 200 patients, 23% greater than 65 had some probable cognitive impairment. Another important consideration, particularly in the ICU, which is such a sleep disruptive environment, is how our sleep patterns change with age. There is impaired sleep quantity and quality. And I think any of us who are grizzled in this room can attest to that. It occurs in more than 50% of individuals greater than 65. There's increasing shallow sleep, stage 1 and 2, with rapid awakening, increasing waking episodes during the night, not to mention going to the bathroom. Decreased deep sleep, stage 3 and 4, in the restorative REM sleep, and an impaired ability to adjust sleep-wake rhythms, especially in unfamiliar environments such as the ICU. And this leads to nighttime restlessness, so the patients get zonked with a benzodiazepine, and so they sleep through the day when they're supposed to be really up and about, and an increased risk of ICU delirium. So this is another thing that should be taken into consideration. And pictures worth 1,000 words, and this shows graphically what happens to REM sleep as we age, and the incidence of waking progressive increase as we get older. Back in 30 years ago, this is an article that was published in the New England Journal of Medicine advocating for development of acute care elderly units, the units really specifically designed for the aged patient, with a prepared environment that was ergonomically designed to limit falls and disorientation, patient-centered care with daily functional assessment by a multidisciplinary team, protocols to improve self-care and mobility and sleep, and medical care review, a review of daily medications and procedures, discharge planning with a medical social worker. Today, we know that all these principles that were elucidated are integrated into our ICU care. And simple things like giving the patient their reading glasses, giving them a tablet, getting the family to interact with them can make an enormous difference to the quality of their ICU stay, and not only delirium, but PTSD. And that brings us to post-intensive care syndrome, which is defined in a review by Dale Needham, which is multidisciplinary. He works at Hopkins, that post-intensive care syndrome occurs proportionately to the acuity and the duration of the ICU. If the patient has been in cardiogenic shock, septic shock, required mechanical ventilation, they're going to have a much greater incidence of ICU delirium with terrifying hallucinations, which can be recounted and may continue. And the family is traumatized as much as the patient, resulting in symptoms of anxiety, PTSD, depression, functional disability, permanent cognitive dysfunction, particularly with things like problem solving, multitasking, judgment, akin to a patient who suffered a stroke and needs a prolonged recovery. Short-term memory loss, impaired attention, loss of independence, ability to work, and a high incidence of nursing home placement. And obviously this creates an emotional and a financial burden to the patient and the family. Finally, we need to take a step back and think about, what outcomes are important to our older patients. And short-term mortality data, 30-day mortality, hospital readmission, are important for Medicare, but they may not be realistic for the individual patient. We need to have more focus on setting expectations of what they can expect in the long term. And long term, we're measuring sometimes in months or a few years, but it needs to be quality of life. And we should be talking about disability-free years as a target, functional status, cognitive function, independent activity, and return to work or study. These should be the overarching goals that we should assess and try to achieve when we're working with our surgical, cardiology, internal medicine colleagues in dealing with individual patients. This is a relatively detailed slide, but I think it says a great deal. As Carol Hodgson, I had the privilege of taking an extended sabbatical in 2017 at Monash University Hospital in Melbourne, and Carol is a leader in that group, and they're able to bring together data from all medical centers in Australia and New Zealand, and I learned a great deal about ICU outcomes from her. And what she's putting in here is that this gray circle is disability measured by the WHO Disability Assessment Scale, and all the things that contribute ultimately to the green circle and the patient's quality of life. So their pre-illness state, and then the effects of critical illness on their mobility, cognition, participation in society, work-home roles, relationships, self-care, the patient's resilience and ability to adapt, and the environment that they go to when they're discharged. All these contribute to ultimately what we're trying to achieve is to get our patients back to the quality of life that they would like to have. Our cardiology colleagues have recognized this in a statement from the American Heart Association in 2017, prioritizing functional capacity as a principal endpoint for therapies oriented to older adults with cardiovascular disease. And I think that's the take-home message from this morning. What are the unsolved questions? What is the impact of the cost constraints on healthcare that we now face on elderly care? Are we going to have to prioritize care from one group to another? How can we better define prognosis, post-ICU trajectory, and long-term outcomes? Which elderly patient subgroups are most likely to benefit from ICU care? Perhaps we need to be paying more attention to that. One size does not fit all. And how can we best integrate the elderly patient's wishes into decision-making, spending time getting a sense of what their values are and what is important to them? This becomes really crucial in the ICU when we're talking about changing to comfort care from active care and deciding, and our discussions with the patient and the family to get a sense of what is important to them. Finally, I've always admired and enjoyed reading Oliver Sacks, who came from Britain to San Francisco and underwent his training in neurology here in the Bay Area, and then practiced back in New York. He was a real character, and I'd advocate his posthumous biography. He died of melanoma back in 2015, and the book was published after his death. But it's really an extraordinary account of his life. But what I took from this is this, that we've come to medicalize aging, frailty, and death, treating them as if they were just one more clinical problem to overcome. However, it's not only medicine that's needed in one's declining years of life. It's life with meaning, a life as rich and full as possible under the circumstances. And thank you for inviting me to make my life richer and fuller by returning to my alma mater here, which has been a real great pleasure. Thanks very much. Do we have any time for questions?
No, I was going to say I have mics and I'll move. So let's start with you. Thank you, Dr. Sladen. That was a great lecture. And I'm even reflecting on the very public case of an elderly um, person going through critical illness that we've all been kind of reading through the news of our Pope, who was in the ICU for a couple of weeks and now recently discharged. And we all know, those who know intensive care and the post-ICU syndrome, that his road to recovery is just beginning, although you never read anything about that. I guess my question, I have several questions and I look forward to spending time with you later today, but if you were to list, some of those causes of harm that we currently remain unaddressed in our daily clinical practice in the ICU, what comes to mind? If you were to walk around a unit and say, if resources was not an issue, if time and energy was not an issue, this is what I like to, these are the sources of harm that I like to address.
I think the first source of harm is the amount of attention or lack of attention that we give to public health. And if you think about it, so many of our patients we are seeing, and set the scene, obviously, as an anesthesiologist, often the first time you see the patient is when they're just about to go into the operating room. In the ICU, the first time, if you're dealing with postoperative care, is when they come from the operating room. We're not involved in planning, in assessment, unless we are really active in the preoperative clinic. And we all live in our silos. And I think that is, one of the biggest challenges we face. And first of all, we're not there with the family and the patient ahead of time, setting expectations of what's going to happen. We're not talking to the surgeon in the sense of saying, do you really want to do, a mitral valve and a triple cabbage on this patient who's 85 years old and, can barely move, and so I think that there's a great deal of that, so a lot of what we're dealing with has to do with the fact that the patient is really at an end stage of a chronic disease, and that is a category of patients who we have the most difficult time with. Obviously, there are young patients who have acute catastrophic illness, work in a surgery trauma unit. It's a very different set of expectations. But I think that the discourse needs to be freely between the teams that take care of the patient and what I've had the privilege of living through, anyone at this stage, when I was an anesthesia resident, no pulse oximetry, no capnometry, no indwelling arterial lines, and today just an extraordinary environment. But every time a new device comes on board, it brings its own set of problems. So now we have patients that we can keep alive with VA, ECMO, putting devices, and it adds another set of problems: hemocompatibility, stroke, infection, and so on. So it's a moving target. I don't think we can simply say, but ultimately, I think I feel very deeply about the lack of primary health care with so many patients. I mean, just my own environment, just getting a primary healthcare physician is a challenge. Having a meaningful ongoing relationship with a physician is a challenge. Getting a consult is a challenge. So by the time we see the patients, there are so many things that may have been done differently to set that patient up for their acute illness, that, we just have to do the best we can. And I think some of the principles that I know you use in your practice, which is engaging the family, engaging the patient, trying to create a better environment, being aware of the potential for delirium and post-intensive care syndrome. At this point in time, I think it's already the best things we can do. I also do think that it's really important, if you're working in a post-operative care unit, that the ICU team and the surgical team are aligned, because nothing is worse than if the patient or family get mixed messages from the two teams. And if you're going to have a patient care conference, you've got to have a huddle where everybody decides this is what we are in agreement about. This is the message we're going to, I think, communicate. And I also think I wish in retrospect that I had the opportunity to work more closely with Wes Ely and his group and set up post-intensive care clinics, because I think it's really so important to help patients. If you read his book, he describes one of the things that he did in his career, which is extraordinary, is that he noted all the patients that he took care of and the devastating consequences of somebody who's been in an ICU for 3 or 4 weeks. We've become so much more aware with COVID than before, but it's always been there. So I think those are some of the things that, I thought about more and more as I got towards the end of my clinical career.
Thank you for an excellent talk. I have one question for you. How do you communicate this information to the hospital leadership? Our hospital is inclined on doing more cases because our business model of medicine is conflicted because of RVU units, more procedures, more revenue. So not every patient is the perfect candidate for every surgery. Not every surgery is the right answer for every patient. And this information gets somehow lost in translation when we are under the pressure of doing more and more cases. And I think the reason this is a very relevant question for us is we are looking for a position of vice chair of perioperative outcomes. And this position actually will have some sort of these tough calls to take. Is this the right candidate that we should be operating on? So how would you approach that?
I think what hospital administrations understand most is return on investment. And so the way that I would approach it is to say, look, your return on investment has to be along the lines, the more you load up front in terms of preoperative discussion, preparation, appropriate selection of patients, the less it's going to cost you in terms of ICU length of stay, hospital length of stay, readmissions, postoperative infections. That's the sort of tack that I would take. And I think that as an anesthesia team and an ICU team, the more we can demonstrate value to the hospital admission by very careful performance improvement projects in terms of, catheter-related infections, urinary tract infections, ICU length of stay. Look, we did this. It's going to cost so much, but this is what the outcome is going to be. I think that's really the only practical way that one can achieve those. So I think having a robust preoperative clinic that can really work together, it has to be multidisciplinary in the sense of working with, both internal medicine and with surgery in terms of understanding what is going to give the patient the best outcome and what's going to cost the hospital the least. That's the language that gets understood, I think.
Thank you so much for a really wonderful talk. Certainly many themes that resonate for any of us who work in the ICU, let alone in a hospital. I'm curious where you see the balance between, all of this data that you've presented where we know patients don't have that robustness and resilience as they age to tolerate a lot of the extreme therapies that we can apply in an ICU. Where do you see the balance between that? And if we look at kind of our ethical framework, so autonomy, which you've highlighted, equity and access, the balance between patient autonomy and perhaps a desire to pursue a lot of these therapies, a minimization of the perceived risk that we apply to ourselves versus perhaps some degree of paternalism as physicians who know this data.
Well, that's a tough question because I think—
If you could just solve that for us.
Yeah, but it has to be individualized to the patient. I don't think one can make blanket statements. I think probably one of the most important concepts that I felt was, missing a lot during my clinical career was setting expectations. And I don't mean just setting expectations for the patient and the family, but setting expectations for our surgical and medical colleagues. And I think that's something that we need more discourse and collaboration on, because I think if we can set the expectations and say, look, you can do this, but we need to expect that this patient's going to be in the ICU for a week or 2 weeks to require mechanical ventilation. And I've sat in on conferences with a surgeon who said, you actually have a 90% chance of not making it out of the ICU. And the response of the daughter, who was a pediatrician, said, "You mean there's a 10% chance that he'll survive?" And the patient was then subjected to 10 days of ICU care. That was awful for everybody. So I think it also has to do with the way that things are presented, and we should stay away from percentages and just talk specifically what to expect. What do you expect? What do you hope for from this? And set realistic expectations. I think if we have the opportunity, I know very often in acute situations we don't. Patient comes in, they're on ECMO, now where do we go? Is this a bridge to transplant or bridge to nowhere? And I think the more we can talk to each other about agreeing on what the expectations are, I think we can individualize. Patients and families are devastated when things happen that they weren't expecting, as we all are. We're going through that right now, I think, generically. But so I think that's something, if we focus more on setting appropriate expectations globally for an individual patient, it will be better for all of us.
I think one vulnerability to that, we experience it here and certainly at the VA, where we also are involved in the medical ICUs, where we don't have that whole preoperative screening process. Somebody takes on an unexpected turn for the worse, and because as attendings, us who actually know this data are spread pretty thin. And who do we dispense to the scene of the crime? But kind of the junioroid people whose view of critical illness might be the next procedure, that shift, maybe that month, if they're really good. And unfortunately, I think sometimes by just going through the motions, we become this one-way valve where we end up or we take in a lot of patients that really will not benefit from critical care, and perhaps don't have the people that can express that to families and other caregivers at the scene of injury. And so we sometimes get a little bit carried away there. I'm just wondering if there's any pointers on how to get this a little bit better than we're doing right now.
Well, in the old days, the patient would have a primary care doc who not only did home visits, but would keep in touch with the patient and the family throughout the hospital, right? Those are long gone. My kind of ideal nirvana would be to have a nurse practitioner who would be there on admission and take the patient through the hospital course and discharge, and be the conduit for all the various communications that need to occur. I vividly remember taking care of a gentleman who had been working at a very high level on computer science and had a devastating heart attack, eventually ended up getting a VAD, and he couldn't make liftoff. We'd get him extubated, reintubated, out of the unit, into the unit. And his wife was getting more and more frustrated and angry. And when I sat down and talked with her, what she came out with is teams. I'm so sick of teams. Every week there's a new team and they're asking the same questions over and over again. And it's very hard for us to get that perspective, that from a patient's point of view, you're seeing new faces every day. And, my adage has been, every physician needs to be a patient at some point to really appreciate what our patients are going through. So I think that continuity of communication, recognizing that each patient has a trajectory through their hospital course, and there needs to be something that ties that together, has been what is really lacking. And we're all working under such extreme pressure, taking care of so many patients, doing multiple sign-outs, and that's what gets lost. And I think that would potentially be a way of addressing it.
I think, thank you, Dr. Sladen. That was amazing and very relevant to all the stuff that we're facing, whether it's in the ICU or in the OR today. We will conclude our session right now, if that's okay. And then, if you're staying around here for a minute, maybe there are other questions that come up. People can walk up to you. Is that okay?
Absolutely.
Okay.
Thank you.